2.5-fold. My last case is a 55-year-old male, diabetes, hypertension, stable CAD, developed a angina. He admitted that he has got a recent relationship conflict with his wife and acute sleep loss for 4 days, just 4 days. And remember that acute sleep loss can provoke precipitate a cardiovascular event like angina or even a heart failure also. Ladies and gentlemen, sleep is an important thing, and restoring it helps us to restore the health, metabolic control, immunity, cognition, and facilitating recovery from diseases. Of course, a good laugh and long sleep are the two best cues for the anything. This is my last slide. I want you all to practice. I appeal all of you to practice. This is something about sleep hygiene. Go to bed at the same time every night and wake up at the same time, even on weekends and holidays. That is more important. Bedroom should be dark and quiet with a comfortable temperature, and bedroom is only for the sleep and intimacy. Avoid gadgets, avoid the late night or late evening feast, caffeine, cigarette and alcohol. Do some breathing exercise, warm shower, reading books if you don't get into your sleep. If you have any trouble in falling into sleep for more than 20 minutes, come back, leave, do some gentle activities, then enter if you feel again sleepy again. So that's a very important thing about the sleep hygiene. So with this, I again thank you all for the patient listening. Thank you.
Thank you, sir. It's an excellent presentation. Usually we, in diabetes, we usually concentrate on diet and exercise. How sleep is important and sleep hygiene. It's a wonderful presentation. How sleep deprivation leads to the glycemic worsening. It's a good awareness for the audience. Thank Dr. Chandrasekhar. So any questions will be in later part of the session. Thank you, sir.
Yes, thank you.
Dr. S.N. Narasimhan, sir, Vice Chairman, Lipid Association of India and Vice President, World Hypertension League, and Medical Director, Armora Heart Care in Chennai.
Chairpersons, good afternoon everyone. I would like to talk on management of diabetic dyslipidemia. Should we focus on lipid levels or decide as per categories? The cardiovascular disease is the leading cause of death in the world. It claims more lives each year than other non-communicable diseases globally. It is estimated that about 31% of all deaths occurring globally are due to cardiovascular disease. CVD is also a leading cause of death, particularly premature death between the ages of 30 and 70 years. If you look at this data, in 2025, it is estimated that about 20.5 million people are dying globally due to cardiovascular deaths. And then it is estimated, if it goes in the same trend, probably we will be seeing about 35 million people dying due to cardiovascular disease. There is an increase in the cardiovascular prevalence by 90%, increase in the crude mortality by about 73% by 2050. Having seen this record globally, I need to tell you that ICMR India study not only evaluated the prevalence of diabetes in India, but also concentrated on other parameters. It is estimated that the prevalence of dyslipidemia in our country is about 81.2%. The various forms of dyslipidemia, hypercholesterolemia is only 24%, the typical hypertriglyceridemia 32%, the low HDL cholesterol is about 67%, and a high LDL cholesterol is about 20.9%. It is clearly seen that all of us probably are having high triglyceride and low HDL in general. Hypertriglyceridemic states are always accompanied by the elevation of non-HDL cholesterol, small LDL particles, high LDL particle concentration. The non-HDL cholesterol is the greater predictor of cardiovascular risk than LDL cholesterol. If you remove the HDL cholesterol, which is containing about the ApoA, which is an anti-atherogenic, whatever is remaining is considered as a non-HDL cholesterol, and it is just calculated by subtracting the HDL cholesterol from total cholesterol. You get that number, and that is non-HDL cholesterol, which contains LDL, IDL, VLDL, VLDL remnants, lipoprotein little a, chylomicron remnants. LDL is an independent and modifiable risk factor for atherosclerotic cardiovascular disease. It has been proved beyond doubt. I need to emphasize that LDL plays a crucial role in atherosclerotic process. If you look at this particular projection, it gives you an impression about the cardiovascular health highway, and one has to decide what to implement during the primordial prevention. One has to decide about the primary prevention. If we don't do that, probably people will land in the problem of acute coronary syndrome, where you need to introduce the secondary prevention strategies. But there is a narrow street where people probably can get blocked there and get problems of acute coronary syndrome or sudden cardiac death. That should not happen. So we need to probably have this sort of marathon, not only for prevention of atherosclerotic cardiovascular disease, but also for LDL cholesterol lowering. All the ways you need to have this sort of LDL cholesterol marathon. So what to do, when to start, what to start, and how intensive it should be. These are the things which need to be decided by the so-called healthcare provider who probably teaches the patients. If you look at 1 millimole of LDL cholesterol reduction, that is about 38.7 milligrams of LDL cholesterol. If it gets reduced, you get a benefit. At the end of 3 years, you get a reduction of 20%. At the end of 5 years, the reduction in the cardiovascular events to the extent of 25%. If somebody continues to have for a period of 40 years, you can expect that the reduction comes down by about 50 to 55%. Amazing information that probably should prompt you that we need to adopt the technique of lowering the LDL cholesterol to the maximum extent possible. At least by 1 millimole of LDL cholesterol reduction by 38.7 milligrams will go a long way to prevent the atherosclerotic cardiovascular disease. So ladies and gentlemen, our attention must be lowering LDL cholesterol and keeping it low throughout our life, even in people with diabetes. Let me now try to tell you something about what to do when you have increased levels of LDL. Should we focus only on LDL all the time to reduce the problem of atherosclerotic cardiovascular disease, particularly focusing attention on diabetic dyslipidemia? The good old study, the CART study with the no baseline cardiovascular disease, these people were recruited. One arm received only 10 milligram of atorvastatin, the other arm received only placebo. People were followed up for a period of 3.9 years. Amazing to see the reduction of cardiovascular events to the extent of 37%. In fact, the study was prematurely closed at the end of 3.9 years because the investigators wanted to give the benefit even for the placebo arm. Surprising to see that the levels of LDL cholesterol, what was seen as 110, 118 had come down to 82 milligrams. That is the one which is responsible for the reduction of cardiovascular events. In fact, the CART study people did not identify the ideal LDL target value beyond which one can get the benefit. The study which was conducted in people with hypertension, even in people with diabetes also, with associated hypertension, is the ASCOT study, which has gone to prove that if you are bringing down the LDL cholesterol to the levels of 83 milligrams, you get a benefit of reduction by about 23% in people with diabetes and hypertension. But now, recently, last year, there is a publication which had come out, 20 years follow-up of the same people who were recruited for this ASCOT study. The investigators were lucky to get those people under their observation. It is clearly seen those people who were very strict in controlling not only diabetes, hypertension, but also in addition they were taking the atorvastatin 10 milligram, had gone to show that 19% reduction in non-fatal MI, fatal CHD by about 19% and cardiovascular mortality by 14%. It is clearly seen with this evidence that underscores the importance of early statin initiation in high-risk hypertensive patients, including people with the diabetes. Even short-term LDL lowering may yield the decades of cardiovascular protection. Apart from these two studies, I need to tell you that there is another study called TNT, Retreat to New Target. This study was conducted in people with the chronic stable angina. Till that time, only about 10 milligram of atorvastatin was given to those people. But these investigators wanted to identify, one arm received 80 milligram of atorvastatin, the other arm received only 10 milligram of atorvastatin. Surprising to see, there is a 25% reduction in the cardiovascular events in those people who received high dose statin, particularly in people with the diabetes. The other one is a heart protection study, HPS study. 20,000 people were recruited in this study. 6,000 of them were having diabetes, both type 1 and type 2 diabetes. All of them were given this high simvastatin dose of 40 milligram, which had shown that there is a good reduction of cardiovascular events, not only in people with no baseline cardiovascular disease to the extent of about 33% reduction, but those people with diabetes, including type 1 diabetes, there is a reduction of cardiovascular events to the extent of 22%. So, in fact, the investigators of heart protection study, who were the first one to say, we were not able to identify what should be the lowest level of LDL cholesterol beyond which the benefits are not seen. The concept of that particular lower the better concept started emerging. Prove It To Me 22 trial was conducted in acute coronary syndrome. Go to the last level, that is less than 40 milligram. You get a benefit of nearly reduction of 40%. 40% reduction in cardiovascular events. So, if you are reducing it to lowest levels even in acute coronary syndrome, you get the maximum benefit. So, if you are reducing the LDL cholesterol to the extent of 50% reduction, you get a benefit of 50% reduction in cardiovascular event. Very, very simple information, very simple message. 50 milligram reduction in LDL cholesterol probably will lead to a reduction by about half. But surprisingly, in the real world scenario, many of them are not able to control the LDL cholesterol even to the levels less than 70 milligram. Nearly 40% of them are lacking behind. This is an excellent data. Suppose somebody receives the drugs at the age of 30 years and you have a good follow-up. The number of cardiovascular events in those people who received the drugs at the age of 30 years is less compared to people who are given drugs at the age of 50 years. Please remember that. The early initiation is most important information that I should share. So the evidences as far the LDL lowering is concerned, 1, earlier the better. Number 2, lower the better. With that in mind, let me now try to take you to our understanding about the residual risk. Okay, you started treating LDL cholesterol, but you need to remember further reduction of LDL cholesterol by giving a combination drugs. Will that be in a position to help us to reduce the cardiovascular risk? So cholesterol risk, triglyceride risk, LPA risk, diabetes risk, pro-inflammatory risk, and then the thrombotic risk. Now I'll take you only to the cholesterol risk. You have good data with respect to the PCSK9 inhibitor as well as the ezetimibe. Ezetimibe was tried in a trial called Improve It trial, where only about 10 milligram of ezetimibe combined with the simvastatin has shown 53 milligram drop to that level. That had got reflected to 14% risk reduction in those people with the diabetes when compared to people without diabetes. So people with the diabetes, when they received ezetimibe plus statin combination, they did better when compared to people who did not receive this combination, thereby forcing us to prescribe this particular drug in those people with the diabetes, in those people in whom you have a polyvascular disease. The next trial is the evolocumab. 4-year trial has shown at the end of 4 weeks, 1 month, you get a benefit of reduction of LDL cholesterol which touched about 30 milligram. This 30 milligram reduction LDL cholesterol to that level had got reflected to the levels of reduction of cardiovascular risk by 15%. Investigators found even those people who reached the levels of 10 milligram at the end of 4 weeks, 1 month after evolocumab injection, they were followed up. They had seen double the benefit. What was seen as 15% became 30%. Thereby telling you that you need to start early, you need to give a reduction of LDL cholesterol as much as possible. The other study is about alirocumab, which had again shown reduction of the levels of atherosclerotic cardiovascular risk in this group of patients who received alirocumab is about 15%. Even alirocumab study, that is Odyssey trial, people had reached 15 milligram, 1.5. They have shown double the benefit when compared to the people who reach the levels up to 20 milligrams. Look at the one that I put a red line. Baseline value 116. The last one, high dose of statin plus a PCSK9 inhibitor. You give a combination, what is going to happen? Just look at the level. What was seen as 116 milligram of LDL touched 23 milligrams. Touched only 23 milligrams. So ladies and gentlemen, I have already told you, earlier the better, lower the better, even lower is even better. And then we'll now take you to the extended study that is called long-term evolocumab in patients with established atherosclerotic cardiovascular disease. What happened here in this, the original drug, parent drug, evolocumab was given, followed up. The placebo arm people, at the end of 12 weeks, they were asked to take evolocumab, and that resulted in reduction of events. The mean LDL cholesterol values here 29 milligrams. People were shifted from the placebo group to the evolocumab group. They were all followed up. People who received later from placebo to evolocumab did not show good. Whereas the people who originally received right from the beginning evolocumab, they have shown benefits with 8.4 years of follow-up. 8.4 years of follow-up. Again, a very, very strong evidence to tell you that the PCSK9 inhibitor evolocumab has shown a maximum benefit, that longer duration of treatment is most important. In patients with atherosclerotic cardiovascular disease, long-term achievement of lower LDL cholesterol levels, even levels less than 20 milligram, has shown the maximum benefit to the lower risk of cardiovascular outcomes with no significant safety outcomes. There is no increase in hemorrhagic stroke, there is no new onset diabetes, only injection site reactions. Rest of the things were all not there, were not encountered at all. So now tell you that earlier the better, lower the better, even lower is even better. The last one is the longer the better, longer the better. So ladies and gentlemen, please remember these four things. 1, earlier the better. 2, lower the better. 3, even lower is even better. And the last one, longer the better. I think that is the message what I thought I should show you line after line, so that you will get an impression that how important it is to reduce LDL cholesterol to get a maximum benefit for your patients with reduction of atherosclerotic cardiovascular events. In this 4-year trial, it is also seen those people reach the levels of 30 milligram, still they have an event rate about 14.4%, thereby showing you need to go away from LDL. What is the one that you should talk now? TG levels. So LDL levels over. Look at TG. Are there evidence? Prominent trial failed to show by using a pemafibrate negative study. Is there a study to say that we can give some drugs to reduce not only triglyceride to some extent, but I get a maximum benefit? Yes, reduce your trial. Which had used icosapent ethyl ester, 2 grams in the morning, 2 grams in the evening, given for these patients, had shown a benefit of reduction of cardiovascular events to the extent of 25% the primary endpoint, and then to the extent of 26% the secondary endpoints. The ADA today tells you that those people with the diabetes, with one risk factor, those people with the ASCVD, those people in whom you have already reached the LDL cholesterol levels less than 70 milligrams, those are the people who can receive the icosapent ethyl ester for 2 grams in the morning, 2 grams in the evening, to get the maximum reduction of atherosclerotic cardiovascular events beyond LDL cholesterol reduction. That's the message about non-HDL. You should concentrate on non-HDL. It is much more important in people with diabetes when compared to people without diabetes. There are any number of studies. Odyssey study started showing there is a reduction of non-HDL cholesterol to the extent of 32.5% in those people who received alirocumab. It is a PCSK9 inhibitor. Can we go it? That is the one aspect of the question that I raised was over. Can we decide it as per the risk categories? The ESA guidelines started telling us that it should be high risk people or very high risk people should keep the levels less than 55 milligram. The Lipid Association of India came out with the recommendation of only 50 milligram in this group. There also they mentioned about diabetes, first type 1 diabetes, type 2 diabetes, lesser duration, longer duration, more than 20 years, high risk, less than 10 years, not a high risk, moderate risk, like that they divided. I don't want to confuse you by giving all this information. Suffice to say, their recommendation only 55 milligrams, very high risk. But we were recommending 50 milligrams for very high risk people. This is about our recommendation, not a crowded slide, but I will tell you, I will make it simple for you. This is from Lipid Association of India, which had come out with the recommendation that low risk, moderate risk, high risk, very high risk. Low risk, no risk factor or 1 risk factor. Moderate risk, 2 risk factors. High risk, 3 risk factors. Very high risk, polyvascular disease or people with recurrent attacks. Extreme risk, polyvascular disease with recurrent attacks, it is familial hypercholesteremia, risk B. So we started reducing it to the levels of 30 milligram. Extreme risk group people, B category, should receive the drugs to get the level of LDL cholesterol down to 30 milligram. So we need to focus not only on LDL levels but also to decide about the risk categories. So find out what is the baseline LDL. Find out how much of reduction of LDL is required. With these two, you arrive at absolute reduction of LDL cholesterol. Find out the baseline risk. What should be the relative risk reduction that is obtained in the studies? Obtain the absolute risk reduction. So you are arriving at one absolute risk reduction, then absolute reduction in LDL cholesterol. Both are required for you to see whether the patient is showing a good response to LDL lowering. So this is the one important slide, what I thought I should show it to you as a slide from Lipid Association of India, divided into two groups. One is diabetes without ASCVD, the diabetes with ASCVD. Suppose somebody is diabetic, no zero risk factor or only one risk factor, he comes under the category of high risk, in whom you should keep the levels less than 70, 70, 70, not even 100. So people who have target organ damage, more than 2 risk factors, very high risk, keep it less than 50. People in whom have established ASCVD, acute coronary syndrome, diabetes, category A, category B. Category A, bring it down to levels of 50, optional 30. Category B, very high risk, extreme risk, recurrent attacks of stroke, peripheral vascular disease or a polyvascular disease, diabetes with the established atherosclerotic cardiovascular disease, homozygous familial hypercholesterolemia or a heterozygous familial hypercholesterolemia, keep the levels less than 30 milligram. That's the recommendation. The recent drug is inclisiran. I don't want to dwell here because of the time, which is not sufficient for me. Bempedoic acid has come to the market, again an important drug which can be added down to the statins. The last trial, we started a trial with a small number of patients, 122 patients recruited with acute coronary syndrome were all going for a PCI. Those people were taken into consideration for the study. We used high-dose statin, 2 PCS in the ezetimibe. The third drug is a bempedoic acid, or so one is the rosuvastatin 40 milligram, ezetimibe 10 milligram, bempedoic acid 180 milligram, has shown a reduction of LDL cholesterol even at the end of 6 weeks. It is maintained much more. So we are actually thrilled to see these results, which was released by the Lipid Association of India. Most recent, this year 2025, released by the American College of Cardiology. You need to have a good discussion with the patient. Patient interaction is important. Family history, very important. Hypertension, lipids including lipoprotein little, tobacco use, subclinical atherosclerosis by calcium score, diabetes and its complications need to be taken into consideration. Use any calculator or look at only our algorithm. You identify the patient's risk and then the medical history. If you go by these things, it is possible to treat this patient. Lifestyle modification, statin, non-statin drugs. So ladies and gentlemen, we need to move away from the high dose statin to tolerable doses of statin plus ezetimibe plus PCSK9 inhibitor or bempedoic acid. That should be the strategy. Try to use the available lipid lowering agents to make the LDL cholesterol to come down further to reach the levels as you want in your patient to give him a maximum relief of reduction of cardiovascular event. Thank you very much, ladies and gentlemen, for patient listening.
Sir, for the insightful presentation on treating dyslipidemia and diabetes, because diabetes is a vascular disease and treating dyslipidemia is very crucial. Thank you for the wonderful awareness on treating dyslipidemia, sir. Sir, when you start the PCSK in any case particular instead of statins in your PCSK inhibitors, any special usage in a OPD patient, outpatient?
In those patients with acute coronary syndrome, don't worry about the LDL cholesterol values. If the patient is having a familial hypercholesterolemia as per the LDL values, there is a strong family history, premature coronary artery disease and death, he is a candidate who is going to get recurrence of events. So levels of LDL cholesterol may be high. You use a high dose statin plus an ezetimibe plus a PCSK9 inhibitor straight away. You should give it. Patient, diabetes, hypertension, smoker, long duration of diabetes with a CKD problem started, patient has developed acute coronary syndrome, never hesitate to use these drugs, including a PCSK9 inhibitor. Familial homozygous hypercholesterolemia, use PCSK9 inhibitor. Heterozygous, no problem at all, there is no coronary artery disease, but there is a family history, try to bring down the cholesterol values, use PCSK9 inhibitor. This morning also I received a message for one of my patients in whom I wanted a LPA. She was asking me, what is this LPA? Then I discussed about the LPA. I just told her, she is a very educated lady. This morning I received a message saying that her LPA level is 185. Just like that, I took my father for the laboratory test, what he wanted. Incidentally, I also wanted my cholesterol level. Surprisingly, sir, my cholesterol level is 185. That correlates with the patient's father history. He had aortic valvular stenosis, operated. Number one. He has got a coronary artery disease. Number two. His cholesterol levels are also high. I wanted an LPA. This lady also went and gave the sample. LPA levels were raised. Then indication for PCSK9 inhibitor is to use in that situation where LPA is markedly raised.
Thank you, sir. We invite Dr. Chandrasekhar sir for the stage. Any questions to Dr. Narasimhan sir and Chandrasekhar sir?
Every time I get this question in any meeting, Seroregulators are both the PPAR alpha and the gamma agonist, number one. It can bring down the blood sugar to some extent, number two. HbA levels probably can come down in a long duration of therapy. It is recommended only for diabetic dyslipidemia. No doubt it brings down the triglyceride levels, but there is no cardiovascular outcome data as on today.
Sir, my respectful wishes to Dr. Narasimhan, who was my teacher in Stanley, 1985-87, the TR unit.
Okay.
Sir.
So nice
sir,
to see you here. Please.
Sir, in diabetics with the normal LDL, can we start a statin early, sir? A normal LDL, normal lipid profile in diabetics.
In diabetes. The recommendation from Lipid Association of India, the moment you make a diagnosis of diabetes in an individual, type 2, start statin also simultaneously. That's the recommendation. ADA tells you above the age of 40, you can give it. Between 20 and 39, see whether the patient has got a high cardiovascular risk. Use the calculator in the United States, ACC AHA calculator. Identify whether the patient has got a risk of developing a cardiovascular disease in the next 10 years. If the risk is more than 10, you try to start statin. That's the recommendation from ADA.
Sir, is inclisiran better than the PCSK9, sir? Because that inclisiran, because it's yearly, because we pay our patients they cannot afford the PCSK9 inhibitors.
Yeah.
Why inclisiran? What is your opinion?
It's a very good drug. In addition, I need to tell you that's a recently introduced drug. It is actually stopping it is actually a small interfering RNA which goes and stops the production of PCSK9. So it gives advantages. When compared to PCSK9 inhibitor like avalokimab, alirocumab, inclisiran also had shown good results in the form of reduction of LDL cholesterol. But the reduction of LDL cholesterol is much more with this when compared to this. Maybe about 5 to 6 milligrams lesser, number one. Number two, in acute coronary syndrome, only avalokimab and alirocumab were tried and not inclisiran. We need to wait for the studies. Patient-centered data that is available with the inclisiran also shows that there is going to be some sort of cardiovascular benefit as per the data available today. Yesterday, FDA has approved inclisiran to treat any patient who is willing to take this particular drug without any complications, without any comorbid conditions. If the fellow wants to take this injection of inclisiran, he should be allowed.
Thank you, sir.
Sir, Chandrasekhar sir.
Lecture, sir. But there is no
you are lipid authority, sir. But phenofibrate, in the lecture there is no phenofibrate usage.
The drug has been there with us for the past 5 decades. There is no acceptable cardiovascular outcome. It can be used only in those patients in whom you have more than 500 milligrams of triglyceride, with or without diabetes, to prevent pancreatitis. That's all.
Sir, Chandrasekhar sir. Sir, role of melatonin supplementation for this sleep.
Yeah, melatonin, like there are only 2 studies to support its use in insomnia. Mainly we use in certain situations when there is a jet lag, like we can use the melatonin, not for the social jet lag, but in patients who have some difficulty in initiating the sleep, like where the sleep latency is increased, where we can use. So that is the 2. And number 3 is in pediatric thing, like people with neurodegenerative diseases, particularly involving the children and adolescents. We have some trials with melatonin.
Regarding LPA, sir, LPA, I got a couple of patients with a high LPA, 50, 55, 60, and so far I have not seen any problem in them. So will they be likely to get a problem in the years to come by, or there is no other molecule, right now there is no molecule to treat for LPA?
Yeah, it is a genetic disorder, autosomal dominant type of inheritance. There is a strong family history of coronary artery disease and a premature coronary artery disease, or death in the family. Think about LPA as a cause. Try to ask the patient's relatives to go for LPA screening. Okay, if LPA is between 20 to 49, consider as a moderate risk. Above 50, there is a risk. Above 100, definitely risk is there. In those patients, you need to intervene. At present, there is no recommendation to treat LPA. The drug that has been tried was aspirin, can reduce the LPA, but aspirin has got disadvantages in the form of hemorrhagic tendencies, so better not to use it. If you are able to reduce the LDL cholesterol sufficiently with the drugs that are available with you, that itself will take care of the injury that is going to be created by the LPA. Because LDL, when you measure, it not only gives the cholesterol content of LDL, it also gives the cholesterol content of LPA. So reduce that. Statins can increase the initial increase in the LPA, but people say it is only the large buoyant LDL cholesterol which are going up and not the small dense LDL cholesterol. If you have a combination like this, for example, LPA is increased. I had a patient who had myocardial infarction. He came with a stroke later. Till that time I did not do LPA. I wanted him to go for LPA. 185. Acute coronary syndrome. He survived. We gave him all medications. No PCSK9 inhibitor. I told him there is no recommendation from FDA for PCSK9 inhibitor, but I can give you. Please tell me whether I can give you, because you have got a atherosclerotic cardiovascular disease in both areas. Can I give it? He could not afford, so I had to stop.
So right now there is no molecule. Right now there is no molecule to address LPA.
Yeah, correct. Perfectly correct.
Excuse me, sir. We had a study telling that if you take inclisiran right from 30 years of age, once inclisiran, sir, inclisiran from 30 years of age once a year, you will not get heart attack. Is it true, sir? Inclisiran from 30 years of age once a year if they take. Those who are having, it was told in an seminar,
I don't think that should be taken as a message.
No, sir, that was told. They are claiming do you have a drug that will prevent diabetes?
No.
The cardiologist was asking the diabetologist. So I'm just inquisitive about it.
No, because it is not at all recommended like that. The drug is not recommended like that.
Yes, sir. Thank you, sir. Sir, to Dr. Chandrasekhar, sir, you were telling about one 46-year-old man, RTA, that microsleep. I didn't catch it. Please kindly explain to me, sir.
Yeah, actually, the patients who are having less duration of the sleep with fragmentation, sleep fragmentation. In the daytime, they may have a microsleep. So somebody is feeling sleepy is different, and they'll sleep for microsleep. Microsleep by definition is when sleep intrude into the wakefulness. Somebody is wakeful, but transient